Hello, everyone, and thank you for attending Health for the World's Radiology Grand Rounds. We sincerely appreciate your being here. I'd like to take this opportunity to welcome our esteemed speaker today. Dr. Isabel Newton is a board-certified diagnostic and interventional radiologist for the UC San Diego healthcare system. She is an associate professor in the Department of Radiology, where she also functions as the director for the IR residency program, as well as the co-director for the T32-funded Clinician Scientist Radiology Residency Program. She obtained a medical degree from Wake Forest School of Medicine, where she also earned her doctorate from the Department of Neurobiology and Anatomy. She completed a residency and fellowship training both at the UC San Diego School of Medicine. Dr. Newton specializes now in the treatment of hepatic malignancies and heads the VA Liver Tumor Board there at UCSD. She's also involved in several research endeavors, one of which is to better understand and target stem cells thought to be involved in liver cancer, as well as to evaluate immunologic responses after thermal ablation of those cancers. Certainly, we at Health for the World are excited and absolutely honored to have such a pioneer in the field of radiology speak with us today. Dr. Newton, we cannot thank you enough. You may begin whenever you're ready.
Okay. Thank you, Elliot, and thank you all for this opportunity. It's singular. I've been looking forward to it for some time. I'm going to be talking to you today about radiation physics and safety, so biology and how you can be safe. And I have no relevant disclosures to this, only to express my deep gratitude to all of you who are involved with Health for the World and to all of you who have tuned in today. So we're going to start with the basics, how these fluoroscopic images are generated. So over here is kind of a schema of the fluoroscopy machine. You have the source, which is usually beneath the patient, and you have the detector, which traditionally has been called the image intensifier or the II. Now it's not the sort of analog detector that it used to be. It tends to be a digital detector, and so we'll refer to it as the detector. The grid is usually meant to remove photons that do not contribute to the image. The collimator helps to shape the beam and shape the field of view. But one thing I want you to notice is the cone shape of the X-rays that come out, the photons that come out. And that's important because as you bring the patient closer to the source, the dose to the patient goes up, and also the field of view is smaller. As you bring the patient away from the source, the dose is going to go down and the field of view is going to be larger. You can see with that triangle there. All the magic happens after the detector. You've got great computers that make the image, and so you can actually improve an image at this phase without cost to the patient or to you in terms of dose. This is just two images of a fluoroscopy machine. This is the kind top right that is similar to the ones that we use in interventional radiology. And this is a mini fluor machine. And so in this case, many times it's even with the tiny ones that are used in hand surgery, the patient's hand may be on the detector itself and not a space as we have in interventional radiology. So this is where the source is. It's important to know where the source is because the closer you are to the source, the closer you are to the dose. So it's one very important principle that I want you to leave with is the fact that scatter radiation is highest where the beam enters the patient's skin. And so on the left, we have an image, sort of a heat map image of the radiation dose without a skirt. On the right, it's with a skirt. So these are skirts that are added to the table. So you can see that without the skirt, the highest dose is in the region of the interventional radiologist or the practitioner, that might generate new interventional radiologists or practitioners. So this gonadal region is a very sensitive one, and we like to make sure that that is protected. And so we're going to talk about how to protect that. But one important way is with a skirt. So you can see how that changes the dose spray that occurs. If you're a tall person, then you are nice and out of this region. You don't get to really evaluate how tall I am, but I'm more with my face down in here. So it's important to understand the way that this scatter radiation is distributed so you can most protect yourself and the people who are operating with you. So let's talk about physics. It's not just for physicists. And the point is to understand how these images are generated so that we can create diagnostic quality images, not gorgeous images necessarily, to understand artifacts and how to mitigate them, and to protect both patients, yourself, and your trainees, or if you're a trainee, you're attending, from the harmful effects of radiation. So let's talk with radiation interactions. We'll start here. Beam meets the tissue. So there are many components for the interactions. First are the properties of the beam. So let's define these. So the energy of the photons is the kV, the voltage. The higher the voltage, the more ability for these high voltage, high energy photons to penetrate tissue. Less attenuation means fewer of them get caught up in the tissue and more of them reach the detector. So once they've all reached the detector, you have lower contrast, because the contrast comes from the differential arrival of photons to the detector. So if you drive them all through at high voltage, they're all going to get there. You don't get a very contrasted image. The number of photons, the MA, the more photons you have, the more opportunity for the photons to meet the detector, but also the more opportunity for these photons to interact with tissue and contribute to dose. Because I want you to remember that dose is only those photons that gets hung up in the tissue. There's also properties of the tissue that we need to consider. So photons are less able to penetrate tissues that are dense, that have a high Z or atomic number, or tissues that are thick. So if I could stand in front of you now, I am thicker in a side orientation than I am front to back. And so if you're doing a lateral view, I am going to have thicker tissues than if you did a frontal view. That's not the case for all of my patients at the VA. Some of them are quite circumferentially equal. Density from least to most is very important to remember. If you're going through the lungs, which are mostly air, most of these photons are going to fly through. If you're going through metal, which is very, very high Z, the photons are going to get caught up and not get to the detector. So this is an important concept, because our fluoroscopy machines use an automatic exposure control, which averages over the tissues we're looking at, and says either give me more photons or I've had enough. And it kind of modulates how many photons are driven through it, and sometimes the energy. So if you are looking at an area that is, let's say, the upper abdomen, and you're including part of the lung and you're not interested in the lung, it's important to remove that part, because then the automatic exposure control is averaging over a larger variety of tissues that may not be relevant. And so the contrast of your image is going to suffer, and you're going to have an incorrect number of photons being administered to achieve the same type of diagnostic image that you'd like to achieve. We've talked about tissue thickness, but the important thing about tissue thickness is thicker body parts remove more X-rays, that they attenuate more X-rays than thinner parts, and they produce more scatter. So radiation interactions are like football. Now, I have to let you know that I have absolutely no idea about football. So this is more like radiation interactions are like my imagination of football. So here we have a photon, and his goal is to drive through and reach the detector. But here we have no patient, so it's very easy. He just goes through and he meets the detector. Here we put in a patient. This patient happens to be thick. He is also of high atomic number, and it's hard for our poor photon to get there. So he never reaches the detector. He never contributes to the image. Now, if we ramp up our photon and we get a more energetic photon, this photon may be able to drive through these thick tissues or the high atomic number and reach the detector and contribute to the image. If you want to increase your probability of getting through, though, you add more X-rays, which is, as we said, MA. So more photons is more MA. More MA has more X-rays to reach the detector. And if you're also increasing the kV or the voltage, you have more energetic, more number of X-rays, and you have a higher probability of reaching the detector. However, in some instances, there's just so much dense tissue that it doesn't matter what you do, you're not going to reach the detector. And that's if you're just trying to image something that's just straight metallic. So one source of image degradation is this idea of noise. And so I put here two paintings by George Seurat, who's the pointillist painter who I always think about when I think about noise. So in this series of photographs above, you see the most noisy image, the noisiest on the left, then slightly less noisy as you go to the right, and you see the perfect images on the right. We're not aiming for perfect images in our fluoroscopy. We're aiming for diagnostic images. So for a good radiologist, it may be image enough, it may be education enough to see these two paintings by Seurat, and you see, it's the Eiffel Tower, it's a man in profile. And so same thing here, in the second image, we already can see it's a gentleman taking a photograph. So let's talk about some of the sources of noise. The number one source of noise is something called quantum model. And I always joke that if I had a metal band, that would be my band name because it just sounds super cool. But what quantum model is it describes a random variation in the number of photons that reach the detector in any area of the detector. So it's almost like that splatter painting or the pointillist. It's just this kind of random event. There are many other factors that can influence the amount of noise in an image. And of course, the reason why you care about noise is because it degrades the quality of the image. And the less noise, the sharper the image. So we talked about MA and KV. So if you have too few photons, they're not going to be enough that reach the detector. You're going to end up with a very grainy image, like the one on the left. KV, if you have a bunch of photons, but they don't have enough energy to drive through the tissues, then they may not reach the detector in sufficient quantities. So if you're trying to reach the detector while penetrating thicker tissues, an obese patient or lateral views, you must either increase the dose, KV, or increase the dose, MA, or use more energetic beams, which is KV. Resolution. So one concept that is important for you to understand is that magnification comes at a cost. There are two kinds of magnification. There's electronic magnification and there is geometric magnification. So remember at the beginning, we talked about moving the patient further away or closer to the source. The closer the patient is to the source, the smaller the field of view, but the more magnified that image is. So that's called geometric magnification. Electronic magnification occurs through electronic means through the machine itself. There's a third kind, which is the magnification that could happen in the post-processing when I pointed to the area at the top. And that comes to no cost at all. And that's simply just magging the pixels. You don't get any more information, you just make them larger. But when you're using geometric or electronic magnification, the smaller detector area requires more photons to go through so that you get the same number of photons in the detector. And so you're getting, so you can maintain that same level of noise. So it increases your dose. Sometimes you have to increase the number of photons and sometimes the energy of the photons, usually the number, to keep the noise constant. The duration of acquisition is something we think about in interventional radiology quite a bit because we do fluoro runs. So longer fluoro pulses can increase your signal, but inevitably this is when the patient decides to cough or shake their leg or otherwise try to escape the table, and that causes motion blurring. Then a source of noise that's very important is scattered radiation. So radiation, the scatter, kind of bounces off in linear fashion. It's bouncing off of everywhere. It doesn't turn corners. But when it bounces off of something and returns back to the detector, those are nonsensical photons. They're not contributing to the image in any way that allows us to see what's going on inside the patient. So that's called scattered radiation. So the scattered radiation that you don't absorb, that bounces off of you or anything else, can reach the detector and degrade the image. As I mentioned, thicker body parts or more obese will produce higher scatter. And also, the larger your field of view, so a lack of collimation, this idea of shrinking the field of view to only include the field of interest, can cause more scatter as well. So a setup for noise and fluoroscopy is, as I mentioned, thick tissue, so obese habitus, arms in the way because those increase the thickness and they include bone, which is quite dense, or a lateral view. I mentioned to you, I'm thicker in the lateral view than I am in the AP view, and that's often the case for most patients. And a lack of collimation. I'm driving this home because these are highly tested concepts and ones that can keep the dose down for you and for the patient and other operators. And finally, long acquisition with motion blurring. So here we have 3 images that were obtained in a lateral view. This is when we're doing a transjugular liver biopsy or starting a TIPS procedure. Sometimes we do this lateral view to make sure that we are in the right hepatic vein. And if we are, the catheter should be pointing to the spine. So this is really kind of a rough and dirty thing that we do, but it very closely or clearly illustrates what I'm talking about. So the image on the left is and I would normally ask you this, but you're all out all over the world, which is thrilling to think about. This is the grainiest image. So the image with the most noise, so the highest quantum model. And you can see it's got all these sort of grainy appearance. And what is causing that? Well, in this case, there's this arm that's in the way. So we have the lateral image. We didn't bother to bring the arm up. And so we're trying to pass the same number of photons to reach the detector, but they're kind of getting hung up. So we have fewer photons contributing to the image. It's still diagnostic because we can see that the catheter is pointing to the spine. So we could be done there, but it's not the most elegant technique. What's wrong here? In the middle image, we have failed to collimate to remove the air. And as I mentioned, the automatic exposure control is this automatic loop that says, all right, you've given me these different densities. I have to average across them and send the correct number of photons to get there. So you have this kind of burned out appearance to the air. So we didn't collimate. And you're still able to see, but it has been at a great cost of many photons. This image over here is a really good one because we have collimated. We have no arm in the way. And you can see very clearly the catheter pointing to the spine. The important thing, though, is to remember that the closer you are to the source, the higher the dose. And so you can get a lateral image by swinging your C-arm in either direction. So why ever would you swing it so that the source is closer to you? Because look, you're in the red zone. You could be over here. So just swing it in the opposite direction. Put the detector on your side. I hope I've helped to dispel any myths that the closer you are to the detector, or if you have the source pointing at you, that you would somehow have greater dose. And that's because of this. So here you have your X-ray tube. The patient is here. The patient actually eclipses most of the dose. So here, these rays are the scatter radiation. Most of the scatter goes back towards the X-ray tube or the source and not towards the receptor. So here you are. Unfortunately, they've drawn this IR as a man, which I have to acquiesce. Most of them are, but I would like to see one with a woman here near the image receptor, being very cognizant of the fact that the image dose is there. So it tells you that's where you should stand. So how can we use dose wisely to make diagnostic images, not necessarily gorgeous images? And this is really my challenge to you. So the factors affecting dose are the photon number, the MA, and the energy, which are the KV. And some of these factors are sort of built into your system. The tube filtration, and the tube filtration kind of expresses which photons are already filtered out that don't even come through. And those are ones that are very low energy or very high energy, are unlikely to contribute to your image in any sensible way. The generator voltage and the current, those things you don't modulate so much. The pulse rate and the number of image taken are ones that you can modulate. So the pulse rate, I would recommend dropping down to as low as you possibly can and to experiment with that. I think many times we have it up to 7 or higher, sometimes 15. We have it down to 3 and have been able to do just fine. And then fluoroscopy time. I think a lot of people put a whole lot of emphasis on fluoroscopy time. If you pay attention, the fluoroscopy time and the dose are not always, don't always predict one versus the other, because it depends so much on what you're imaging. So if you're imaging the arm, your fluoroscopy time can be much longer than if you're imaging the abdomen before you reach a certain dose. Beam geometry. So again, the distance between the patient, the source, and the detector. So the further away the patient is from the source, the larger the field of view, the lower the magnification and the lower the source. Collimation, being able to remove areas that you don't care about. And then photon attenuation. So we talked about patient body habitus and the thickness of images, of the tissues being imaged. That's how many photons are removed from reaching the detector. And that's very important because that's how we develop our image at all, is the differential arrival of these photons to the detector. And some are attenuated or removed because of these thicker tissues, and some arrive. But when they all get removed, you don't get an image. Or if they all get drive through, you don't get an image. And that's why we have to maintain conditions that support this differential arrival of these photons. I'm repeating this because these tend to be difficult concepts, and sometimes people get these concepts when expressed in one way or not another. So if you have immediately understood them, I apologize for the repetition. Finally, it is extremely important that you remember that scatter radiation is directly proportional to patient dose. So if you happen to not be an altruistic person, which I doubt that you are not, given that you're involved with this fantastic organization, but if you're not worried about your patient and the dose to them, you should at least be worried about the dose to yourself. So reducing the dose to your patient reduces the dose to yourself and to the other people near you who are the other operators. So now we're going to shift and talk about safety. So the biological effects of radiation. And so to go with our theme of Superman, Superman, has this kind of complex relationship with radiation. And I'm not a DC comic kind of person, but he had exposure to radiation. And then here he is being kind of held in radiation. And obviously, even though he's Superman, it has detrimental effects to him too. So don't be a Superman or a Superwoman. Make sure you protect yourself. And the first step is to understand the biological effects of radiation. So we can roughly divide the effects of radiation into two categories, stochastic and deterministic. And we'll talk about this, and I'll point out some little issues with this dichotomous categorization in a minute. So the stochastic effects are those that depend on chance. They may or they may not occur. The more absorbed dose means a higher probability of developing them, but there's no threshold. There's no tiny dose that's safe. There's no high dose at which you know for certain you're going to get them. Theoretically, any dose could cause a stochastic effect of radiation. The severity is also independent. So you can have a little tiny dose and it can cause an aggressive cancer. You can have a large dose and it could cause no cancer or curable cancer. It's not predictable. So the examples are radiation-induced cancer and genetic modifications, so like germline modifications that you can pass down. The best way of sort of predicting this is a way that is very difficult to understand because of the very nature of stochastic effects of radiation, and that's the dose area product. And so I show you sort of what the output is at the end of an exam. You have the exposures, whether the fluoro is normal or boost, the time the beam was on, AK and DAP, we'll be talking about air chroma in a minute. The dose area product is the best predictor of the stochastic effects of radiation because it's the total energy deposited across the entire exposed skin. Now, what does this mean? Since I told you there's no threshold and there's no magic number to look out for, what I encourage you to do instead is to notice these numbers and notice them as a function of different procedures that you do. And so when you fall outside of the mean, you start to ask yourself, what did I really do the best dose saving effects that I could do? The risk of cancer actually decreases as a person gets older. So that's why we have in the US this Image Wisely campaign because newborns and children are much more radiosensitive than adults. And the radiosensitivity is much higher in females than in males, and that's because of breast cancer and the incidence of breast cancer. And so I want you to remember this because if you work with young people, as most of us in academia do, you want to be sure that you're making sure that your trainees protect themselves. And then if you have patients that are young, that you're not doing unnecessary exams on them. The converse of that I see is many times people are so afraid of radiation, they don't do a fully diagnostic exam. And so they end up having to repeat many aspects. So in an attempt to mitigate the amount of dose at the outset, they step off the fluoroscopy pedal too early, and then they have to repeat a run. So really understanding how to use this well is the tool, the best way to reduce dose. So you saw Superman at the beginning. With great power comes great responsibility, and you're able to see through people. So your responsibility is to make sure you use it wisely. This is a graph that just shows what happens to radiosensitivity as you get older. Females or women are much more radiosensitive throughout life, and that again is accounted by breast cancer. Males lower, but really around sort of 20s and 30s is sort of the inflection point where it starts to go down. And so most of my patients are in this area. And so you can over-exaggerate your concern for radiosensitivity depending on where your patient is on this scale. So, you know, the risk of someone dying from an acute illness is much higher than the risk of their developing a cancer in 25 years, you know, if they're at 70. So at that point, do what you need to do. But recognize that, you know, you also need to take care because the scatter radiation goes to you and the other operators. So the deterministic, excuse me, the deterministic effects of radiation are ones that we have come to understand through some unfortunate experiments that have occurred as a result of history. These are the effects of radiation that occur after a threshold. Remember, Stochastic did not have a threshold, and so the threshold here is 2 gray. We're usually about 2 gray, so 2,000 milligray. Above that dose, the severity of symptoms is dose dependent. And the effects are skin redness or burns, hair loss, infertility, and impaired hematopoiesis. Cataracts have classically been under the deterministic effects of radiation, but they're starting to be reclassified as sort of a blended stochastic and deterministic, meaning you could have cataracts at very, very low doses below the known threshold, but that there is kind of a cumulative dose to the eye that has a result in cataracts. So how do we figure this out? We have the atomic bombs, observation after radiation exposure in these situations, patients who've received numerous exams, and then experiments on animals. So whereas dose area product is the best way of predicting stochastic effects, air kerma is the best way of predicting deterministic effects or skin injury. This is radiation at a point, and this is usually expressed in milligray. This is a number that you can actually hang your hat on. So here we have a dose of 1,484.9 milligray. So have we passed the threshold? No, we have not. The threshold is 2 gray or 2,000 milligray. So as long as we're below that, we should be okay for deterministic effects. Here we have an image of dermal necrosis. It's on the back because this patient was purportedly laying on their back having a procedure, probably a cardiac one. We like to say that we don't do this in IR. It might have been an EVAR, who knows. But you see that aerial dermal necrosis because the source came to the back, and they must have reached threshold doses of greater than 12 gray. And you can see this here. And these, it's very important to know that these effects are not immediate. So if you look after the case and you don't have any redness, well, maybe you looked too soon, because even the early transient erythema will not develop until after 2 or sometimes 24 hours after the procedure. And then the more erythema reaction, or the main erythema reaction, which is more permanent or more lasting, doesn't occur until a threshold dose of around 6, and that you won't see until about a week and a half. So in these cases, if you do exceed these thresholds, usually around 5 is the threshold that I begin to really worry about, and I try to keep all of my doses under 3. Then you need to schedule a follow-up to see these patients either yourself or in a derm clinic at 3 weeks and 6 weeks to make sure that these don't occur. And the reason why they might not occur even if you reach a total dose here is that there's this idea that if you weren't always focusing on that same area, if you're spreading your dose around, then one point in the skin may not have received that total cumulative dose. So it's very important to follow your patients. The cataract risk is more to operators, is how we think about this. So this particular type of cataract that we're concerned about are posterior subcapsular cataracts. And that's what's shown here in D. The large image in A is just an image of a cataract in general in plain light. But these slit lamp images below show various different kinds of cataracts. So if you're going to an eye doctor, I wouldn't recommend, or there is no recommendation now that if you have chronic low-level radiation that you need to go to an eye doctor at any certain frequency. But if you're going anyway, it's important to let them know, hey, I have chronic low-level radiation exposure. Please evaluate me for cataracts, particularly the posterior subcapsular kind, because they are preceded by posterior subcapsular opacities. So there's a way to kind of know if they're coming. But if you do what I ask of you and beg of you to do, you may never get to this point. And we'll talk about that in a minute. So let's sum up this whole concept. The effects of radiation, the deterministic effects are like drinking. You must consume a threshold dose in order to get drunk, just like it would be with alcohol. After that dose, the more you drink, the drunker you get. Some of the effects of too much alcohol are reversible, some are not, and sometimes it can result in death. Same thing with deterministic effects. Stochastic effects, on the other hand, are like gambling, or at least like playing the lottery. So even if you enter the lottery once, you could become a winner of the worst prize ever, nonetheless. But if you buy more tickets, which is kind of a proxy for increasing your dose, you increase your chances of winning. So that's why more dose has a higher probability of getting a stochastic effect, simply because you're playing more often. The value of your prize, or the severity, does not depend on how often you enter or how many times you get this. So you could have many imaging studies with a lot of dose and get a little thyroid cancer that's completely curable, or not, or you could get a very bad cancer 25 years later. It's impossible to know. So now we're going to talk about how to protect yourselves. And this is not just you, but it's for patients and the peoples next to you. And so again, I told you I'm not a DC comic person, but when I was looking up these images, because I really like symmetry and I love imagery, I found that Superman actually had a little lead suit that he wore to protect himself from kryptonite. And then there are all these people over the blogosphere going, well, why didn't he just wear that all the time? I think it's because he has a TV antenna and a screen in there and a television receiver. And, as someone who has to wear 20 pounds of lead, I like to take it off after a procedure. So I imagine that he felt the same way, and it would look pretty goofy to go around. It looks a whole lot better with that cape, but I'll leave it up to you. So here's an image of me in my lead when I was a fellow. I have a thyroid shield here that drapes over, doesn't go around, which actually helps me. I have some claustrophobia. There is a sort of a waist strap that lifts everything off of my shoulders, so I'm not carried down. You can see my guns. I was working out. I'm wearing my leaded glasses, which help protect my eyes. I have a skirt, and then the thickness of my my radiation protection at this point is 1 millimeter of lead equivalent. So like, Superman, he's wearing his lead, I'm wearing a lead equivalent, and I'm wearing the maximal when it overlies. And that's because the area that we showed earlier that is at highest exposure with the scatter radiation, if you don't have the skirt, is the gonadal region. And we'd like to make future IRs. I did my part. I have 3 children who haven't busted in yet to this presentation, but anything can happen. So let's talk about the primary methods for radiation protection. Time, you want to minimize the time the beam is on, but don't do it at the cost of actually making the diagnosis. Distance, stand away from the source, and that's where the beam enters the patient. Remember, that's the point of highest scatter radiation. And so this scatter radiation and radiation in general follows the law, the inverse square law. So you can take one step back and that radiation will plummet. It will fall off exponentially. And you probably can remember that from those heat maps that I showed you. Shielding, you want to wear the protective gear like the ones that I wore, and also wear always your dosimeter so that you can be able to measure the actual dose you're getting. And here's my dosimeter on the outside. It's flipped over, so you want to flip it back. Use X-ray barriers and movable shields, and I'll show you some. And then reduce your dose to the patient. So as I mentioned, if you haven't gotten to the point, I really think collimation is important and it takes time, and you should do it. And avoid placing unnecessary objects in the field of view. When I give, this lecture to my my vascular surgery friends, I try to encourage them to get all of the metal, gear out of the way. They don't need to have, clamps or anything in there. And then they have always syringes full of contrast in the field of view. We have tubing that can get that out. Get your hands out of the way. We don't need to see your great ring and all that kind of stuff. So those are all very good techniques. And then use your dose sparing techniques like we talked about before. So here's some images of things that you absolutely should be using. In A, we have this acrylic shield, and this helps enormously to reduce the amount of scatter radiation to your chest, to your neck, and to your eyes. And so this shield, at least where I work, is prepped with a plastic bag that keeps it sterile so you can move it around during the case. And then you can actually also decrease the scatter radiation to yourself by using disposable shields that are basically a drape that's impregnated with some material that blocks the scatter radiation. The important thing though with these is you don't want to include them in the field of view because they will increase your dose, because remember that automatic exposure control will pump out more photons to kind of drive through these things that are blocking it. Here's that skirt, the gonad saving skirt. You should make sure that that's always hung up and is in place. And if you're doing a fistula, that it's not in the field of view again, because it will increase your dose. And then this is a movable stand shield in C here. This is really good for your nurse to stand behind, or anesthesia, or if you're doing exams where you're using fluoro-CT, you can stand behind this as well. Here are some different images of different glasses. Basically, the take-home message here is the more you look like a minion or pretty dorky, like you're in the middle of a lab experiment or beaker, the more protective they're going to be. Here's my former resident who's now in IR in Colorado, Cosette Stahl. She's wearing these glasses and she's demonstrating that if you tilt them at 10 degrees, that offers the most protection because you don't get those scatter beams coming up through that space below your glasses, which is a source of a lot of radiation to your eye. You want wraparound glasses as much as possible because many times you're looking ahead and the patient's over here and the scatter's coming from the side. So just be cognizant of the source of scatter and where it's going. What lead to buy? I get asked this all the time. And I'll tell you, it's difficult. I'll tell you, buy the most protective lead that you can stand and make sure it's comfortable. I like a 2-piece lead that has a full 1 millimeter equivalency, but they'll show you these kinds of graphs. And these graphs are nonsense because they're basically looking at 70 kV, 100 kV. Is that your exposure as the operator? Unless you're laying down on your table and with your full lead on and shooting the beam through yourself, that should not be your exposure. Your exposures are going to be at much lower energies. And so they'll never show you that graph. And so these are different lead versus bismuth, barium, gadolinium, and different combinations. Basically, we don't have the data to say one is better than the other. So again, just buy one that is comfortable and that you will wear because you will be doing this for a long time. And there are significant ergonomic costs to very, very heavy lead. The one that I showed you, I've been in practice now. I finished my fellowship in 2013. I still wear that lead. It's made it through 2 pregnancies. It's great. So here, just to show you, these are some examples. This is my friend Darren Klass. He's an IR in Vancouver, and he's demonstrating how it can be done very well. You've got the lead or the acrylic shield, which has been prepped. He's got his lead glasses on. They're tilted at 10 degrees. He's got his thyroid shield. All his texts are the same way. You can't see this, but there is a skirt. He also is wearing lead. So this is an example of how to do it right. He could go on and get an additional amount of scatter attenuation if he wanted by putting a temporary or disposable shield here. But the way that he has pulled this acrylic shield down is really mitigating most, if not all of that scatter radiation from the source. And he's doing right here a pulmonary embolism procedure. On the other hand, my very good friend, Brooke Spencer, who is a genius in venous reconstruction, she's very tall, so she actually doesn't wear the lead glasses. She knows that I use her as the example. She doesn't wear the lead glasses, and she doesn't have the shield prepped, but she's quite tall, so she's going to be in that cloud where it's in the green zone. You know, when I'm next to her, my head's down here, so I'd be getting all of her radiation. So she is wearing her thyroid shield. She is wearing her lead. There is a skirt here, but there could be a few additional things. And the reason why you want to do this is because you want to obviously protect yourself. Here's an example we see all the time. Someone getting access and we're seeing their hand. We can admire their ring, but you really don't want to become this. You want to be the Superman. You don't want to be the Incredible Hulk. Personally, I would rather be this, but I will leave it up to you what you want to be. So at this point, we have 15 minutes left. I have some questions that I can take you guys through, but I'm happy also to take questions from you.
Dr. Newton, thank you so much for your expertise and your willingness to speak with us today. I think I can speak for everyone. We learned a ton, and I very much enjoyed your presentation.
Great.
I think we may have time to do a bit of both, questions from you and questions from the crowd.
Okay.
We can start with the crowd. One question was about the dosimeter, and is it usually external or internal to the lead gear that you wear?
So if you're only going to wear one dosimeter, you should wear it outside of your lead and on your thyroid shield, up close to your face. That most closely approximates the dose that you're going to receive. If you're issued two, which is it is actually optional, or it's not optional if you're pregnant or trying to get pregnant. If you're issued two, the second one goes beneath your lead on your waistband. So that measures the dose that penetrates the lead and gets to you. And you want it sort of at the level of your abdomen. You can request a second dosimeter. I did when I was planning on getting pregnant, and I measured my dose, and I had no detectable dose from the second one that was below the lead during the time with my with the lead that I wear.
Awesome, thank you so much. We've had a couple more questions come in. I saw one where they wanted to know, how do you go about protecting your hands, and another question about protecting your hair as well.
Great. So protecting your hands, there are products out there. There's attenuating cream, and there are gloves. And the other question that I always get also is, the attenuating bonnets or the hats that you can wear. I'll start with the hands. I don't recommend either the cream or the gloves. The cream has actually gotten a warning from the FDA because it has a higher opportunity for infection, but also your hands should not be in the beam. And you can imagine that if you use gloves that have radiation attenuation, what's going to happen to the dose to the patient? You put this hand in there, it's almost like putting a metal instrument. The dose is going to get driven up. So you're going to, for a part of your body that's not radiosensitive, for a second, you're going to end up driving up the dose to you and to the patient, everything else. I recommend using intermittent fluoro. Keep your hands out of there. With a lot of radiation exposure, you can get arthritis. So just don't put your hands in there. Put the fluoro beam on while you're looking and take it off, or rotate your eye to get your hands out of the beam. As far as the hat, physicists and experts disagree on what to do there. My feeling is don't wear a hat, because what it can do is, if you imagine you're wearing the hat up here, the scatter photons are coming from below up through your glasses or through your face. They are going to go through your head if they can, and your hat is going to make sure they don't exit. And so remember, only the photons that stay in your tissue are the ones that contribute to the dose. And so you're not really having the scatter come from above, you're having the scatter come from below. So I don't wear that type of hat. I can see the questions here. What is the principal challenge to get quality images and the safety in radiology? I think it's education. I think once you know, it's quite easy to do, to balance both. And as you learn, as you become more comfortable with seeing images that have this appearance, this kind of slightly grainier appearance, you can make the same diagnostic images or the same diagnostic conclusions as you would otherwise. There are instances, however, if you're trying to do a GI bleed and it's very, very fine, the patient's quite large, you can increase the photons. Those are times that you spend your photons, but don't spend your photons on some situation where you could get the same answer at a much lower cost. I got a nice comment. At mammography, do we need a thyroid shield? This is an interesting topic. I think the answer right now is no, because in mammo, the doses are quite low and the amount of scatter that reaches at that level is quite low. Another question is, if someone is getting radiation therapy to their breast, do they need a thyroid shield? And that's a much higher dose, right? You're talking 10 gray over many fractions. And the answer is also no. The physicists have shown that the roll-off at that point, at that distance where your thyroid is low, it is not high enough to warrant having the thyroid shield there. And again, you have that idea that if the scatter radiation, you'll just basically reflect these photons back to yourself. What are the radiation doses received by a rad tech? It depends on where the rad tech is standing. So if the rad tech is standing to the side and farther away from the source, they're going to be receiving much lower doses than the person who's standing near the source. Also, and this is something that I exploit, it turns out that the person who's closer to the source, in my case, it's my resident or my fellow, is quite attenuating. And so if you stand behind them, they are going to be eclipsing much of the radiation that you might otherwise be getting. That also means that if you're the person in charge, you need to be reminding them to be using these techniques quite often. And I do that all the time. The question here is, what is your opinion on real-time personal dosimetry in the case of vascular radiology with angiography systems? Real-time personal dosimetry is fantastic if you have access to it. We've used systems before just to test some of the concepts and how good we are at mitigating radiation. And it turns out in our setup, in my lab, we're very good at it. So it can be incredibly instructive and helps you understand and sort of break bad habits. So if you have access, it doesn't have to be all the time. You could borrow a system or have one that you share amongst different hospitals and just test and get an idea of what the real radiation is. And then you can change your practices accordingly. Any opinion on dose tracking system software accuracy? No. And the problem here is dose tracking system. What do you do with this? And so that's what everybody's asking. So right now we're tracking this to sort of move towards imaging more wisely and imaging better. But the question is a 5 gray dose in one exam equivalent to 5 grays over 5 exams over 1 year? Well, any of us who understand radiation biology and the DNA repair mechanisms would say intuitively no, right? If you get 5 grays in one exam, or let's say you have 5 exams that you bring a patient down next day, that's different too. So I think it's important that we track these so that we become cognizant of them, but it's difficult to know what to do with that data. And so I'm not sure about the software accuracy. We record this all in every one of our exams. And some patients are trying to, record their cumulative dose. I think it gives some information, but it's very difficult to extrapolate one-to-one what that means. I have a question. Do you use screen grabs as a means of decreasing dose, especially in kids? All the time. And thank you for bringing that up. So many times you can, when you are doing fluoro, instead of taking a real image, which, you have the capacity to take a real X-ray, and sometimes that's necessary, but most of the time you can just do last image hold. And be careful also when you're using fluoroscopy that you're not standing on the fluoro pedal for a long time to see something that isn't moving. You can step on and off, and then while you're off, see your last image hold and make your diagnosis without continuing to step on the fluoro. Are the limit of radiation received by rad techs? That is only something that you can know if you wear your dosimeter. So there are limits, and I didn't go over these limits because I think they differ depending on where you are in the world, but you should be aware of what the recommended limits are for different organs and when you've reached them. So wear your dosimeter religiously, be aware of the limits in your region, and go over that with your radiation physicist or whoever's monitoring your dosimeters at regular basis. If you're practicing wisely, you shouldn't be reaching these limits. The only time is, I think I reached the limits when I was a fellow, and that's because I didn't have full ability to make them prep to shield and everything. And there wasn't, I wasn't aware of all these things as I am now. Now, as program director, I've made sure that all of my residents and fellows get the training on the very first day of their fellowship, and everyone's empowered to raise their hand and say, look, we're not practicing radiation safety to the fullest extent. Let's stop. Let's prep the shield. Let's do whatever. And you should do the same thing. There's a question, do you ever change the fluoro frame rate through a long abdominal procedure, say a TIPS? Yes. My fluoro frame rate starts, my default is the lowest. And so the only time I change it is to increase it if I have a very difficult case, like a very faint GI bleed or something very fine. I would say I increase my dose probably twice a year. And it's at max, it would be for 5 minutes, and then I go back down. I find that I can do almost pretty much everything at the lowest frame rate, which for us is a 3. And the newer your machine, the better they are. And when I talked about the dose cost of magnification, I will make the caveat that that is much lower on the newer machines. They have managed to engineer them better so that magnification doesn't actually have as high of a dose cost as before. And sometimes magnification can decrease the overall length of the procedure. So don't be afraid to use the tools that you have. Just understand them and know why you're using them and how you can protect yourself and the patient. Which is the time for fluoroscopy to protect at radiologist? I think, perhaps the question is like maybe asking, are there lower times at which you don't need to protect yourself? I think, I'm not sure if that's really what the question is, but I lecture to non-radiologists all the time, to orthopedists, to urologists, to vascular surgeons. And the orthopods, some of them only do hand surgeries. So their doses are quite low. And they ask me, do I really need to wear this? And some they go in just with a thyroid shield. Some don't wear glasses at all. And I tell them, look, you may not be reaching very high doses, but what we don't know are the effects of the low doses. And the data is all over the place. And I'm happy to talk with you guys about this at some other time. But the point is that the threshold, we sort of bounce around that. And in order to show a big effect, you're going to require a large sample size. So whether or not you may not achieve a dose that would give you a deterministic effect of radiation, but as I mentioned to you, stochastic effects can happen at any dose. So it's better just to protect yourself. And also with the eyes, it's a cumulative dose. So you don't really want to risk your eyes when you're someone who makes their livelihood on seeing well. So please wear your glasses. What are the benefits and risks of radiation? This is a question that I think a lot of chiropractors talk about the benefits of radiation, and that idea is hormesis. There is no known and real demonstrable benefit of low dose radiation, and so I don't endorse that. It's not that idea of what doesn't hurt you makes you stronger. I don't believe that with radiation. We, as IRs, get lead gear that's 0.5 millimeter thick. You said 1 millimeter. Is that what we should prefer? No, you get it at 0.5 millimeter, and it's when it overlaps in the front that it becomes 1 millimeter. So that's, and you can see, you'll be able to see that, there are some that are marked 0.25 and at the overlap it's half, and some that are marked 0.5 and at the overlap it's 1. So just see if you have the overlapping. Usually the overlap occurs in the front, so it protects your breasts, it protects your gonads. If you're a woman, make sure you're wearing female lead, because the armholes, if they're very large, you're wearing male lead, you get exposure to your breasts, so you do not want that. Is one piece of lead apron worse than 2 piece? It's not worse, it's less comfortable in my mind. And if it doesn't go around to the other, all the way around, and you're turning around in the case, you're going to be getting a lot of dose and it's not going to be able to escape your body because now you've created a stop on the other side. And so if you're always facing forward, or you're just, a student, one piece lead apron is fine. You're standing far back, but I recommend 2-piece that's goes around your entire body. It's more comfortable. It's more protective. Why do we use Alera principles? The reason why we use Alera principles is for the entire point of this discussion is because we want to use the lowest possible dose that we can to achieve the diagnosis and affect the procedures or the treatments that we can. And if you are like me, I intend to be in this my entire life. I am absolutely energized by being an interventional radiologist. I think it's incredible. You may encounter patients who are only going to have a fluoroscopic procedure once, but you're going to have a fluoroscopic procedure every single day. So use these low doses for yourself, for the young people standing next to you, for the patients. How can we estimate effective dose? Doses most accurately are estimated by putting dosimeters on the patient, but we don't do that. It's not possible to do that. And so we usually estimate our dose. Our physicists will estimate the dose using phantoms and give us kind of an idea. This is probably good enough because if your system is calibrated and is the same, you're really comparing yourself to prior doses, and you're creating a body of experience that you can then compare to going forward. So until it becomes cost effective and feasible to put dosimeters all over the patient, we have to use that method. I see there are more questions and I'm happy to answer them, but I'm cognizant of the time. Would you like me to stop or would you like me to answer these?
It's completely dependent on you. If you have
okay.
you can.
I am.
Speak later. That's fine too. Whatever works.
Yeah. So the next question is 55-inch monitor decreases image quality compared to 22-inch monitor. How do you manage to achieve better image quality? So what that's actually referring to is it's not that the image quality is decreased, is if you have enough information, a 55-inch monitor can have perfect image quality for you to make diagnostic images. It may not look as pretty because you're blowing up these pixels, right? It's the same same amount of information being depicted on a 22-inch screen is going to look much crisper than if it's blown up to about twice the size. But as you get used to looking at these images, you're going to find that these post-processing kind of magnification, which we do, we have very large monitors at the VA. And sometimes I have the techs, they press their mag, which is at no cost to the patient, right? It just mags the image. We can still make our diagnosis based on those. So if you are finding though, that when you blow up to 55 inches, that you're looking at something very, very fine, then use more photons or use more energetic photons, whatever you need to do to penetrate the tissues. But you're going to have to get used to this kind of lower quality and realize it doesn't mean poor diagnosis. It just means you might not want to publish that picture. What is your opinion about eye dosimetry? I don't have much knowledge of eye dosimetry, so I don't have an opinion. I'm sorry about that. I think the best way that we estimate eye dosimetry is through the thyroid shield dosimeter that's on the outside, because it's receiving pretty much what your face and your eyes will get. A kind statement. What is the major difference between lead aprons, gowns versus skirt versus shirt? Again, it's the thickness, how much overlap you have, what the cumulative thickness is, and then comfort. And I can give an entirely separate talk, or my colleague, Quinn Meisinger, has a great talk on ergonomics. And so you got to be doing this for the rest of your life. And so choosing the highest attenuation that's comfortable is important. What's your opinion on the safety of having a drive-through diagnostic X-ray facility together with the COVID swab test to address the fear of patients on entering the hospitals? I don't know. I can't speak about that. I think that, COVID swab tends to have a, right now it depends on which test you're getting, but I think that's what we're relying on to identify people with COVID. X-rays can be positive even when somebody is no longer infectious. In fact, I discovered a patient who had COVID on a CT for an EVAR the other day. I was quite impressed with myself because I'm not just radiologist, but it was a CT, and there was the classic patchy peripheral ground glass opacities, but he was no longer infectious. So I don't know that it would be helpful, and I think it would drive up the amount of radiation unnecessarily. So I would be against it. My question is, how can you tell that the cancer was secondary to radiation versus other factors? You cannot. You cannot. And that's very difficult now. So we're talking about probabilities. And that's why I tell you that the data is quite messy, because it's not like you get a cancer right away. There's some that happen within a 3 year period, kind of lymphoma, thyroid type of stuff. But most of these cancers are in 25 years. And by that time, many patients are no longer with us, or it's difficult to assign causation. Should you record the dose report received by the patient in the case notes? I believe we should, just to help us get used to them and increase awareness. Again, I'm not sure what is done, except once you receive that threshold of 5, at that point, here we must report it to our radiation physicist, and we have to do follow-up with the patient. What are the maximum acceptable variations in linearity? That would be a good question for the physicists. And they do those calibrations, we do not. How do you protect your pediatric patient under fluoro and IR? I don't treat patients that are pediatric patients, but I have reviewed articles on where to place the lead shielding, and you have to be very careful, because if the lead shielding gets included in the area, the field of view, it obviously can increase your dose. That is the only piece of information that I can add to that. Otherwise, I think that's a point of a lot of debate in the pediatric world. I think the best thing to do is to image wisely and try to reduce the amount of radiation your pediatric patients can get. And you can do that with being very adept at ultrasound, or if you have to do cross-sectional imaging, using MR. There are 3 more. I'll answer these 3 more, and then it looks like we'll be done. What are the radiation detector measurements? I think those are what we talked about with the ones that I showed earlier, the DAP and the air kerma. What is your advice on trainees who fear joining IR due to radiation exposure? I talk about that all the time. If you understand, which is why I took so much energy to understand, my last name is Newton. I am related to Isaac. He had no children, so he's a great uncle, but I was terrible at physics in college. It was the worst grade I made, but I pushed through and learned all this, because the more you know, the more you can protect yourself. And I have 3 beautiful children who have behaved very nicely during this. And so you can do that too, if that's your fear. And then, have PPEs affected radiation safety procedures? I don't think they have, because you should be wearing all that below, and you should have all the ability to prep those PPEs to keep them sterile. So with that, it's been such a pleasure. It's an honor, and I commend all of you for this endeavor. It's incredible, and thank you for the opportunity to speak to you.
Thank you so much, Dr. Newton. This was excellent and a wonderful talk. I think you made it very fun also. So I think people really enjoyed this, and there were really lots of questions. Mm-hmm. So, and you're an excellent speaker. Thank you so much for this wonderful talk. We really appreciate this, and you have a wonderful day. And thank you to your kids also who let you do this. I have a 2-year-old, so this is huge,
Great. Yes, me too. All right, well, take care.
Thank you.
Greetings across the world. What a thrill.
Thank you so much.
Okay.
Thank you everyone for joining today, and be safe and have a good day. Take care.
All right. Great. Bye.
Bye.